Hello students, I am Dr. Aditya Kidiyoor and I am your forensic medicine faculty from Manipal MedAce. Today we're going to be going through the INICET November 2024 recall, and there weren't too many questions, but let's immediately get to it. Few disclaimers before we start, mainly that the questions discussed here are purely based on recall, right? And so there may be a few variations, so please bear with us if there's any discrepancies. And once the final questions have been located, procured, at that point in time we'll be updating our Q banks. So please bear with us. Now, the first question that was asked is Marshall's triad is seen in which of the following blast injuries? I hope that you guys remember the class that I took for you where I very specifically talked about the various injuries caused when there is a blast. There are primary injuries, secondary injuries, tertiary injuries, and quaternary injuries. Your primary injuries are mainly due to your blast wave, right? The shock wave injuries. Your secondary is due to flying missiles. And this causes Marshall's triad. Marshall's triad, I hope you guys remember, is contusions, lacerations, and abrasions. These are punctate lacerations. That you remember it. Tertiary has to do with body displacement and falling masonry, and quaternary is with any added on damage like burns or radiation or chemical damage that may happen. And so I hope you guys are also noting that I have put this mark over here. This basically means this is a very straightforward question. You should not waste time. This is a time saver question. Now, for those of you who might need a bit of a jogging of your memory, this is what was covered in class. Notice here the primary injury, secondary, tertiary, quaternary, and also the kinsiary, or the fifth layer of injuries. Now, one very important thing to note over here is that this has been asked previously in the INICET exams. So there is no excuse for you to have not gone through it once, right? So keep this in mind as we move on to question number 2. Now, sorry, before I even get to that, bringing your attention to another thing, this was part of our Q bank as well. I had asked this question with an image, and if you notice over here, same thing was given along with Marshall's triad being mentioned along with the reference as well. So if you guys have gone through even our present Q bank, you would have been able to answer this. So let's move on. Next, question number 2. Which of the following is incorrect about heat exhaustion? Now, I hope that you guys remember there is heat cramps or minus cramps, heat exhaustion, heat syncope, heat prostration, and finally we come with heat stroke. Now, in all of these, the thing that you need to remember is when does sweating stop, right? When does sweating stop? And also, when is there cerebral dysfunction? These two things are very important, and this will help you divide between the two. Now, the main confusion that you can possibly have here is between heat stroke and heat exhaustion, because with cramps there's simply dehydration, and with dehydration you may see orthostatic hypotension, but you will not see altered consciousness. The core temperature of the body will not be above 105 degrees Fahrenheit. It will be around 104 degrees Fahrenheit to 104.5 degrees Fahrenheit. Now, is there a loss of thermoregulatory systems? No, because sweating is still taking place, which means that the body is still trying to maintain the body temperature. So over here in this case, you can immediately rule out the minus cramps. Now, when we're talking about heat exhaustion, here as well, sweating will still be kept in place. So therefore, we already know that this is the correct answer, but let's go through all the other options as well. Orthostatic hypotension is seen. Yes, with significant enough dehydration, it can also be seen. So this is a finding that is seen. Altered consciousness is not seen. See, this is a double negative. You need to be careful. Altered consciousness will be seen in heat stroke, but not in heat exhaustion. So this is also a correct statement with regards to the given criteria, right? Core temperature is below 105 degrees Fahrenheit. This is not correct again, because this again, it would be above this temperature. So the correct answer here would be loss of thermoregulatory mechanisms. Again, this is a time saver question. Do not waste much time with it. It's quite straightforward. In heat exhaustion, thermoregulatory systems will still be intact because sweating is still intact. Okay. Now here's a quick table for you to go through. This was also discussed in class. I hope that you're able to note over here, heat cramps, minus cramps, also known as fireman's cramps. Main thing that's happening here is electrolyte loss through dehydration. Mental state will be normal, very important. Mental state will be normal. Skin will be moist with sweat. Whereas over here with heat exhaustion or heat syncope or heat prostration, there's dehydration. Yes, there's also CVS collapse at later stages. Now, one thing to note over here is these two seem very similar, right? These two seem very similar, but this will also have hypotension, right? Hypotension will also be seen with significant enough dehydration. Then with heat stroke, yes, as you can see over here, we had already mentioned this earlier. I hope that you're able to draw the same comparisons. It will be impaired and the skin will be dry. Now, this was covered in traumatology part 2, and also it has been asked in a previous year's questions. Also very important, we have asked a very similar question in our own Q bank. Notice over here, the concept that was tested was heat stroke versus heat exhaustion. Over here, see, dry skin is going to be noted, along with which you'll notice cerebral dysfunction. Straightforward, everything is mentioned in the explanation along with reference. So if you had gone through our Q bank, you would have definitely been able to answer this because the concept would have been clear. Next, question 3. Methylene blue is used as an antidote for which of the following? Phosphorus, aluminum phosphide, mercury, or nitrites. Now, even if you are unaware of nitrites or of aluminum phosphide or phosphorus or mercury as having a specific antidote, I want you to just think with common sense, even if you didn't know the correct answer immediately, right? If you get flustered, you will definitely answer it wrong. So let's just think with common sense for 1 second. With phosphorus, is there a specific antidote? No, there is no specific antidote for phosphorus poisoning. Aluminum phosphide, is there a specific antidote? No, we know that that also does not exist. With mercury, we would possibly go for some chelating agent, na? And methylene blue, not a chelating agent. So the only thing left would be nitrites. So you can answer it this way also, but there is another way you could have remembered this, which is if you remember from cyanide poisoning. Cyanide poisoning has a kit called the Eli Lilly kit. Okay, it's also known as the Eli Lilly cyanide antidote kit. Now I'll show you the diagram of it in the next page, but know that the answer right now is nitrites. And in the treatment of this Eli Lilly kit, I hope you guys remember, initially they'll be giving amyl nitrate, right? And that will cause for a change to happen in the body, in which you will develop methemoglobin, and for that you will have to give nitrites to deal with that, right? So that will help you with the next step, which is you have to give sodium thiosulfite, which will then create sodium thiocyanate, and that is excreted by the body. Now this is also a very straightforward question. You should not waste time. You can just look through this once again. It's basically what I just described, but note over here that when you use the Eli Lilly cyanide antidote kit, normal hemoglobin with nitrites will give you methemoglobin, right? This methemoglobin with cyanide will give you cyan methemoglobin, and then with cyan methemoglobin thiosulfate, you'll get sodium thiocyanate. So basically, even if you were to give methylene blue, you would be able to treat it. Now this comes both under forensic medicine and also emergency medicine and also just medicine in general medicine, right? So this is where the two subjects overlap, and it is expected that you know this also because this is a previously asked question. It has come across before, and this was covered in our lecture series as well under the asphyxiants 1. And there was a very similar question that was given in the post Q bank. Now I hope you're able to read it, but over here it says what is the mechanism of nitrites in cyanide poisoning, and over here you can see that it forms methemoglobin, and we're going from top to bottom, even with the references it's given as to why it is important. Next, question number 4. This is match the following, and this is sort of an overlap between pharmacology, medicine, psychiatry, and also forensic medicine, but I will deal with it here in forensic medicine because it deals with alcohol and delirium tremens and also benzodiazepine overdose. So even if you didn't know the answer about smoking cessation, you would have still been able to answer the others and have gotten your marks. So what is it? It's quite straightforward, right? Just always remember, right? Alcohol dependence and delirium tremens and alcohol withdrawal is a favorite question for INICET and NEET PG also. So you have absolutely no excuse for not knowing it. This is a very high yield topic, and we have spent a lot of time on it, both in the recalls, in the crash course, and also in the video lectures. So note over here, for alcohol dependence, you can give acamprosite. For delirium tremens, you'll usually give a benzodiazepine. Usually we say diazepam, or you can even give lorazepam, but yeah, you can give oxazepam as well. There's nothing wrong with that. For smoking cessation, yes, varenicline is used, but even if you didn't know this, you would have known definitely that benzodiazepine overdose is treated with flumazenil. This is a specific antidote, right? This is a specific antidote. Here, this is the drug of choice. Benzodiazepines are the drug of choice, right? So these things you do need to know. right? It's quite straightforward, quick way to score marks, so don't waste time in such questions. So this is an INICET favorite question: alcohol withdrawal and delirium tremens treatment. You must know this. Specific antidotes for benzodiazepines, paracetamol poisoning, OP compound poisoning, heavy metal poisoning, methanol poisoning, etc. You must know. You must know on the tip of your fingers. De-addiction of smoking is more commonly dealt with in medicine and psychiatry. I just told you about this. And even by process of elimination, the answer is very clear. Okay. So yes, directly also you could have answered, and indirectly also you could have answered. But yes, this was covered under CNS depressants 1. It was there in our MCQs, and also this is a previously asked question. So you must answer it. Now, question number 5. A schoolboy has consumed some unknown substance and presents to the emergency with pulmonary edema, hypotension, and on examination has positive silver nitrate test. What is the antidote? Now, students, I have to be frank over here. I don't like the way this question is framed. Okay, mainly because of this word here, antidote. Antidote is not existent for this constellation of symptoms. You can say what is the best option for treatment amongst the given options, right? That you can have said. Antidote is not the right word to use here, because it doesn't counteract it in any measure, not whether it is symptomatically, physiologically, physically. It's not doing that. So what is the scenario that is being formed over here? Note few significant findings, right? First thing, unknown substance has been consumed. We know it's an ingested poison. Next, presents to emergency with pulmonary edema and hypotension. Hypotension, pulmonary edema doesn't tell us what it specifically is as a poison, okay? Because it could be any agricultural poison, it could be an organic irritant also, it could even be drugs of abuse like barbiturates also. So over here, just with this much information, we can't tell a lot. However, it says that on examination, there is a positive silver nitrate test, AgNO3, right? This test is used in cases of aluminum phosphide poisoning or cell-phos, right? Cell-phos poisoning is very common, especially in the northern states, and there is no specific antidote for it. Treatment is only symptomatic, and even the hypotension that they've mentioned here, they could have given extra clue. They could have given an extra clue mentioning that it is refractory, right? Severe refractory hypotension, but they have not mentioned that. Straightforward, they mentioned hypotension. So over here, what would the treatment be? Well, let's do process of elimination, right? And immediately we'll get an answer. Can you use atropine here? No, it's not preferred to use atropine over here. Can you use Prussian blue? No, that also does not make sense here. That is more seen in cases of perhaps thallium poisoning. Then you have BAL. This is not a heavy metal, not of much use. So the only thing left is MgSO4. This would be the correct answer because it helps stabilize membranes, right? It's a membrane stabilizer. Okay, so this would be the best answer, MgSO4. Now this was dealt with in class, right? Many students did thank me for this, which is specifically that I told them about this bedside test called a mask test or a filter paper test, when which the mask is impregnated with silver nitrate, and then when you breathe into it, the phosphine gas that is produced by the aluminum phosphide hitting saliva or gastric secretions, phosphine gas is liberated. That phosphine gas, when it touches the silver nitrate, you'll get a black color, right? So that is the bedside test, mask test, also known as silver nitrate test. And the treatment for that is mentioned over here: KMNO4 stomach wash, activated charcoal, paraffin, and MgSO4. MgSO4 is still used in the treatment, but however, there is no specific antidote. This is very important to note. Also, it has a garlicky odor with bloodstained froth and mucosal hemorrhages at autopsy. Along with which, one very important thing, I did mention also very specifically the silver nitrate test, right? So students, you have no excuse. I have mentioned it very clearly. It is a good screening test. It gives a metallic silver, but false positives may also occur through sulfur compounds. It gives a black color. And also another test is ammonium molybdate, and this is confirmatory. So next time the question may come in this vague way, right, where in which they might tell you that ammonium molybdate test gave canary yellow color. So what could the possible poison be? That time you need to have the wherewithal to remember that silver nitrate and ammonium molybdate will both test positive for aluminum phosphide poisoning. Now, this was covered in our lecture notes, also in our workbooks, lecture videos, the MCQs and PYQs, along with recall and crash course. Please do keep in mind aluminum phosphide poisoning, very commonly asked because it's very common in the northern states. Sulfos poisoning, very commonly asked. Now, question number 6. Many students had a problem with this, and I too have a problem with this, and I'll explain why. Let's go through the question first. The substance shown in the image is used in the treatment of, right? And what they've given is these blue powders or blue crystal that they have given. Now, if you work in forensic medicine, you know what they're asking. They're basically talking about copper sulfate. Okay, they're talking about copper sulfate crystals. That is the first thing. But the other problem is they have given no other contributing or additional information for you to come up with a better possible diagnosis, because there are multiple poisons which are blue powdered, right? You may even get DDT or boric acid which has this same thing going on, right? You may even get OP compound which is blue color, but that this is not giving enough clues. Nah? However, it is often given as a spotter for those in who are writing their theory exams. When they're doing the subject in MBBS, it is given as a spotter so that students can quickly identify it. So I don't know why they have given it this way at such a high level. To give such a question is, it doesn't make any sense, but it's been given, so let's move on with it. I'll tell you what the second problem is. Let's look at the options. Options say arsenic, mercury, aluminum phosphide. Now, we know that for arsenic and mercury, you would want a chelating agent, right? Let's say you want to use British anti-Lewisite here, okay? BAL. Now, aluminum phosphide, we know there's no specific treatment for it, but you can use MgSO4, KMNO4, you can use those. So the only thing left is phosphorus. Now, is it correct that it's phosphorus? Yes. There is no doubt that yes, this is the best answer here. But is this method used anymore? No. This treatment methodology is not even used anymore. It is outdated. So I don't know who has asked this question, but I am not a fan of it. But amongst all the given options, it's very clear that phosphorus is the best possible answer. Phosphorus is no longer used anymore in the gastric lavage, but it is still mentioned in some textbooks that you can use it in certain small percentages, but it's not preferred because copper sulfate in itself is a poison. Copper sulfate in itself is a poison, and they want to create the insoluble complex of cupric phosphide, and that itself also has its own problems in the body. So I don't know why they have given this question, but I'm not a fan of this question. However, the approach to this is quite straightforward. It was used in the past, it's not used anymore, right? Mercury and arsenic will require chelating agents, whereas ammonium phosphide, only symptomatic treatment, no such antidote. You can give KMNO, basically what we just discussed, right? But keep in mind, many such questions like this can come, and so you should be on your toes, you should be ready. Okay, question number 7. Which of the following does not inhibit cytochrome C oxidase? So this is basically a question about complex 4, right? Complex 4 of ETC, right? Now, a lot of students asked me, sir, is this a question to do with biochem, FMT, physio, or patho? And I feel this is the wrong way to divide the subjects, because at the end of the day, you need to know all of the disciplines to be able to treat the patient in the most optimum way. Now, all of the options given here are toxic substances which we discuss in forensic medicine and toxicology. So therefore, it does behoove us to know about these things. Now, for those of you who have paid attention in class, you know that cyanide and hydrogen sulfide both have actions on cytochrome C, right? So you already know that these two definitely have. So which does not inhibit, the remaining two must be. Now students, a few of you got confused here also. You thought carbon monoxide seemed likely to be the correct answer, and nitrous oxide was the wrong answer. However, I would like to tell you one thing. Carbon monoxide, while yes, majority of its action is taken via carboxyhemoglobin being formed, there is a small action also on top of the cytochrome C oxidase enzyme, right? So it's apart from just acting on the hemoglobin and causing anemic anoxia, there is also an action on the cytochrome C. So the correct answer here is nitrous oxide. This takes place because it acts via B12. Now, very important for you to know that there is going to be a lot of overlapping between disciplines, especially at a level when you're doing a postgraduate entrance exam, right? So there's going to be a lot of overlap of disciplines and concepts. So please stay smart and sharp. Now, This question has more to do with biochem and physiology and pathology, like I said. However, since the options do contain toxic substances, let's go through them. Cyanide and hydrogen sulfide are very well known as cytochrome C oxidase inhibitors, whereas carbon monoxide has a very slight complex 4 inhibitory effect, and nitrous oxide has no effect here. So this is the right answer. Okay. Now, what were we expecting? What were we expecting from our side as people who are coaching you for your NEET and INICET PG? We expected topics with respect to INICET mainly to deal with things like negligence, mechanical injuries, mechanical asphyxia, agricultural poisoning, and sexual jurisprudence, specifically sexual offenses and medical termination of pregnancy, animal irritants, specifically snakes and scorpions, metallic poisons such as lead, arsenic, mercury, copper, iron, asphyxiant poisons, plant irritants such as datura, semicarpus, argemone, and ricin, and drugs of abuse, mainly alcohol, cocaine, meth, and heroin. But what are the things that we actually got to see this time? Well, we got to see from mechanical injuries, we got to see Marshall's triad, right, which is blast injuries, right, Marshall's triad. Then from agricultural poisoning, we got alphos. Then from metallic poisons, we didn't get anything, but instead we got something from phosphorus, which is a non-metallic poison. Right, from asphyxiants, we did get something about cyanide via the methemoglobin, and with plant irritants we got nothing. Drugs of abuse, we got something from alcohol with respect to the match the followings. So match the following type question came. Now this is what we were expecting, so it somewhat did cover all the things we were expecting. We just didn't expect them to do it in this fashion. Now what has this INICET taught us? What, right, that's also very important to note. The questions for FMT seem to be coming from the same topics. The topics seem to be revolving around the same areas. All the stuff that I have mentioned here with what we were expecting, it has come from the same topics. Now, instead of asking questions horizontally on topics which are on the side, like let's say if they were asking about aluminum phosphide, they could have gone with autopsy findings, right? Given you a scenario where they've told you these are the autopsy findings, what could the possible poison be? Or what could the antidote have been? Or what could the treatment have been if the person had survived? Along those lines, something along those lines. However, they have gone deeper into the same topic, and this has led to them going back into the history of treatment and all the things that were done in the past. So it's not exactly the strongest paper, but it's a paper nonetheless. Can't do anything with it. Then many questions involve knowing specific antidotes. Yes, this, even in recall, I told you, is the greatest skill that you need to have in toxicology. I said this also in crash course. You must know the specific antidotes. Many a times these are time saver questions. Quickly you can answer and move on, right? Then one very important thing, students are very happy. BNS and BNSS and BSA have not been asked, which are the new laws that we have in this country, which have been in effect as of 1st July 2024. But while this is good for students now, next year if you're attempting, please know there's a very high chance something will come, right? And we'll discuss with what may be asked later on, but just know that the main sections are already present on the app, and we've given relevant details and I've given the updates quite in advance. So you should have gone through them before for this exam itself, but for next exam you must. There's no question. Now, how have we fared with respect to preparation from our side, right? The questions were covered in the given materials. So the strike rate for FMT is 7 on 7, which is 100%. We have done everything from our side and provided everything. A few post QB questions were phrased in a way that was not a direct copy. Yes, that is true. We had talked about the same concept. The question may have been a little different, but in the discussion of the concept tested, of talking about how to approach to the answer, we have discussed basically the same concept, and we've given you the answer then and there itself. If you had just attempted that PYQ or even the post QB and read the explanation, the elucidation, you would have definitely got the concept clear in your head. You would have been able to answer everything. Now, one other thing, please keep studying. Do not lose hope. You don't know what's going to happen. You may not get exactly everything you want, but you should not lose hope. Please keep studying. Now, as far as my side of things, I would say the best way to approach forensic medicine through Manipal MedAce is that you go through the lecture videos, the notes, MCQs, which is the MCQs post QB, the previous year questions. Also go through the workbooks and faculty connect. Workbooks had basically all the specific antidotes, right? It was already there. I had given that as a thing along with the Eli Lilly kit. Both of these were given in the workbooks. So if you've done that, you would have had it clear in your memory as well. Lastly, do not lose hope. Again, I'm telling you, do not lose hope. Please stay focused. For now, you just rest for some time. Go and enjoy with your friends, your family, whatever it is. Take time to, wind down a little bit, but then begin preparation for the next step, whatever it is, whether you've cleared it and gotten your PG rank, or whether you're going to be attempting again. Please make sure you take some downtime to spend time with your family and friends. That is very important. And also work hard, and please know that you can always reach out to us here at Manipal MedAce. We are here to help you. We're all in this together, and we want to help you get the rank that you deserve. So please keep that in mind. I'm very proud of you if you've done well, and if you've not done well, don't worry, don't lose hope. There's always a next time. That brings us to the end of this session. Thank you so much, and I hope that this was helpful.